Good evening, ma'am. With your permission, shall I start, ma'am?
Yes, ma. Start.
Screen is visible.
Yes,
Okay,
visible.
okay, okay. So, my case is Mr. XYZ, 26-year-old male patient, residence of Bhilai, Hindu by religion, and he was student by occupation. He is doing a master's in engineering, and the informant of the case is patient himself and his mother. Patient presented with chief complaining of inability to walk for last 15 days and diminution of sensation in the bilateral lower limb for last 20 days. History of present illness: patient was apparently well 30 days back. Then he developed insidious onset abrupt band-like sensation all over his trunk at the level of Jiffy sternum, followed by abnormal tingling sensation and numbness and burning in the right lower limb, followed by involvement of the left lower limb within next 72 hours. Weakness of his right leg occur next day of the sensory symptoms. Weakness of the lower limb affecting both the proximal and distal muscle. Proximal muscle affecting prior to that the distal, as evidenced by he has difficulty from getting up from the chair, squatting position, and getting up from the lying. He has also difficulty in getting up from the lying down position and turning in the bed. He also felt stiffness in the both lower limb and spasm of the flexor muscle was present. On inquiring, he had history of fever for 1 month back, which subsides spontaneously within 3 to 4 days and does not require any hospitalization. Fever was intermittent in nature and fever was mild to low grade. Temperature was 100 degree Fahrenheit maximum and fever was not associated with night sweats, chills or rigor. He took medicine from local medicine shop for the fever, which was of 3 days course, and fever subsided within 3 to 4 days. There was weakness reached its maximum level on third day of sensory symptom developed. There was no electric shock-like sensation radiating from the leg or no shock-like sensation on bending his neck. There was no sharp shooting pain, particular or dermatomal pattern, which increases on coughing, on sneezing. There was no complaining in the upper limb. There was no thinning of the muscle in the lower limb, no muscle fasciculation, no weakness of the upper limb, no weakness of the neck muscle, and respiratory distress was not there. There was no history of headache, vomiting, seizure, speech abnormality, altered mental behavior, or recurrent hiccup. There is no history of urinary urgency, frequency, or retention of the urine. There was no history of palpitation, postural dizziness, loss of sweating, no history of vision loss, double vision, painful eye movement, or double vision. Difficulty. There was no difficulty in chewing, on swallowing, or deviation of the angle of the mouth. In the speech was normal. No, there was no slurring, and on hearing aspect, there was no hearing problem, no tinnitus. There was no history of joint pain, skin rash, alopecia, oral ulcer, or dryness of the mouth in recent past. There was no history of weight loss, decreased appetite, swelling in the body, no past history of any tuberculosis, no history of trauma on the back, no history of recent vaccination or radiation, no history of bleeding diathesis, and no history of taking any recent medication. On past history, there was no significant past history was present. There was no history of medical comorbidity, no history of recent animal bite or vaccination. There was no history of any blood transfusion in the past. In family history, there is no significant family history or such kind of illness was found in his family. On personal history, he was doing masters in engineering, unmarried, and socioeconomic status is upper in modified Kupusami scale. His diet was mixed in and appetite was normal. Sleep is no change in pattern of the sleep. There was no addiction or high risk behavior. There was no deleterious habitus or not exposure to any toxin. And bladder bowel was normal. So summarize the case. A 26-year-old unmarried male patient without right-handed without any pre-existing comorbidity developed acute onset bilateral symmetric spastic paraparesis associated with truncal weakness, pansensory loss in the both lower limb and the trunk up to the sternum level, and the band-like sensation at that level. There was history of fever 1 month back, of the onset of the symptoms, and there was no radicular pain or back pain. There was no history of trauma or tuberculosis.
Okay. So the cranial nerves are they involved? You said bladder and all is not involved, and so many
Not
systemic
involved.
symptoms. No, clinically no cranial nerve involvement.
No, madam.
Okay.
There is no history of any clinical nerve involvement.
Okay. So we will analyze the symptoms first. That is how I try to approach. After that, we will find out the structures involved. You see, you said
Yes,
that the first thing happened 30 days back when the patient had a band-like sensation. No?
yes,
What do you understand by band-like sensation, and what you should differentiate it from? So it, how many segments it, you told it is syphisternum. From the
yes,
syphisternum, up to what level it was spreading? Was it below the whole part of the legs below syphisternum, or was it a suspended band-like sensation?
no, madam. He was telling just the compressing band-like sensation, like he was wearing a belt over his Jiphisternum. He was only limited to the Jiphisternum level and 2 to 3 centimeter below the level. At the
2,
epigastrium
3
level,
centimeters.
actually, it told.
So you see, when somebody is telling that there was a tight sensation in the region of syphisternum, that corresponds to what segment, ma'am? Would you like to say?
Yes, ma'am.
It is
Like to describe the D6 spinal level, madam.
very good. So it is approximately around D6. So it could be coming from the D6 root, or it could come
Yes, ma'am.
from posterior column, or it
Yes,
can
ma'am.
come from, because it was confined to that area. So now the point is, was it coming from the root? Was it coming from the crossing spinothalamic tract at that level? Or was it a posterior column producing a band-like sensation? So these are the three things. When somebody is telling a band-like, when you tell band-like, you give an
Yes, ma'am.
understanding that it is over a long area. It is not exactly over the syphisternum. So band-like means like putting a band around that area. So this can be a root pain or a symptom coming from the crossing spinothalamic tract at that level, or it can be from the posterior column. So how are you
Yes,
going
ma'am.
to differentiate these three? What I teach, of course, your cases may be straightforward, but to make a proper analysis will help in a difficult case.
Yes, ma'am.
So root pains, you clearly told, you have a very good presentation. So root pain will be exactly at that D6 area. If it is a D6 root pain, it will be exactly that segment only. It will not be a broad band, because you use the term band. Band means
Yes,
it
ma'am.
is not in one segment, it is over multiple segments. Second, it will have a sharp quality pain, sharp pain, and it will be shock-like pain. So root pains are sudden, sharp, shock-like, and confined to that particular root. And generally, they will have some precipitating factor like bending or weightlifting, coughing, sneezing, so that they will have precipitating factor, and they will also have some relieving factor. So that when they lie down quietly, it may be relieved, or lying down may be aggravating, depending on the nature of the disease. So lying down pain will be aggravated if there is a destructive lesion, like
Yes, ma'am.
metastasis, osteomyelitis, fractures. Whereas non-destructive disease like disc disease, that will be relieved by lying down. If the pain is
Lying down.
aggravated by lying down, you should think of destructive disease. If it is relieved
If,
by lying down, it is non-destructive disease. So it is not typically looking like a root pain, because it was band-like. So
band-like
it is
sensation.
not looking like a root pain apparently from the history that we have got. Whereas
Yes, ma'am.
band-like pain comes from the posterior column. It will not have a precipitating factor. It will not have relieving factor. It will not be shock-like. It will be like you have put a tight towel around that area. So you will not be able to point out the upper level and the lower level. As if you have tied a towel around in that area, it will be there. It will be broad. It will not have precipitating factor, relieving factor, no sharp quality. it is like a tight band.
Yes, ma'am.
What about the crossing spinothalamic? Because it is suspended in that level. That is why you will not consider the ascending spinothalamic. You will only consider the crossing spinothalamic. So it's a spinothalamic tract pain. So it will be a diffuse burning paresthesia, which is superficial, or it may be a feeling of cold. This also will not have any precipitating factor, relieving factor. So this is the way we differentiate a root pain at D6 level, or a posterior column presenting as a band-like sensation. Third is spinothalamic. Why it is important? Because if it is a root pain, you are going to think of something which is starting from the root, or so it may be from the foramen, it may be a acute disc, or it can be a discitis, or it can be an tuberculous osteomyelitis, which can start in that disc region and go to the adjoining vertebra. So if a root pain is there, it is going to give you a group of differential diagnosis. If it is a tract pain coming from the posterior column is a large myelinated tract. You have got two tracts
Deep
which are
coding.
very, yes. You have got a posterior column and corticospinal tract. They are myelinated, well myelinated tracts. So are you going, he's a young man, previously very well preserved. So is he getting a demyelinating disease? Because posterior column, band pain, band-like sensation, is it a demyelinating disease? Or if it is a spinothalamic tract, crossing spinothalamic tract, that is getting involved first. Then you only clearly told you about mouth ulcers and conjunctival ulcers. So is it some condition like Behçet's disease or vasculitis, which will involve the small fiber? So it's going to give us a etiological clue. So it's important to differentiate root pain from posterior column tract pain and spinothalamic tract pain. Apparently, it looks like a posterior column tract pain because you have described it as a band-like, no precipitating factor, no relieving factor. So as you have rightly asked, you should ask about other posterior column sensations like Lermit sign. You said that there is no lightning-like pain while flexing the spine.
Flexing the neck, yes.
So other posterior column tract pains are Lermit sign. Second, lightning pains. So Lermit sign is a shock-like pain which descends along the spine when the patient flexes the neck, because at that time the posterior column gets stretched. So if it is already sick due to demyelination or any kind of granuloma, then it will get stretched and produce tract pain. Second is a shock lightning pains. What is the typical character of lightning pain? How do you like to tell, ma'am?
Lightning pain it typically is radiate from the ma'am, it is suggestive of any root pain. So it reverts along the
pains are like lightning. We have now described what is a root pain, like what is a posterior column tract pain, and what is a spinothalamic tract pain. Lightning pain is a posterior column tract pain. You see, it is not a root pain. So posterior column tract pains are, one is Lermit sign, second is band-like sensation, third is lightning pains. So like lightning does not respect your nerves, it does not respect your roots, it does not respect your tracts. So it will go across body planes.
Lightning pain, madam, is usually found in the tabes dorsalis or pseudotabes of diabetes.
Posterior column, you see. Forget about the disease, ma. From the history, we should know the anatomy. Then we will decide the etiology. So posterior column produces the lightning pains. So lightning pain is not a root pain, it is a tract pain of the posterior column. Just like a lightning. Lightning does not respect your root or anything. It will go across body planes. Something when they suddenly through. So people might imagine, MI, they might imagine dissection of aorta or perforation of viscus, like duodenal perforation. So suddenly it will strike and go. It will not respect the neurological pathway. It is lightning pain. So third kind of posterior column pain is a lightning pain. Fourth kind of posterior column pain is a deep boring paresthesia. I will tell why all this happen. Deep boring paresthesia is because lightning pains come because it is said that when the posterior column is damaged, the substance P accumulates in the root entry zone. It is not able to flow through the axoplasmic flow. So accumulates in large amount, and that is capable of producing spontaneous pains. That is the explanation for the lightning pains. Next thing you get is the deep boring paresthesia. Deep boring paresthesia means as if your flesh is being pulled out from the bones. That is because proprioceptive afferents go to the posterior column, spindle afferents. So from the muscle, spindle afferents go to the posterior column because it is movement, vibration, position. Mainly it is a spindle afferent. So because of that, you can get deep boring kind of muscle pain. And the next type of posterior column tract pain is an ill-defined glove and stocking. Normal peripheral neuropathies produce glove and stocking type of sensory impairment, but how it manifests, it will be length dependent. It will start from the toes, and by the time it reaches the knees, the upper limb gets involved, because peripheral neuropathies generally are length dependent. So it will start from the toes. Only by the time it reaches the knees, upper limbs get involved. Whereas posterior column tract pain can mimic a peripheral neuropathy by producing glove and stocking type of sensory symptoms. But it will not be respecting the length. It may be in the tip of the toes and the tip of the fingers. That is one way. Second, it can be very bizarre. It can be up to the hip in one leg, and it may be up to the ankle in another leg. And patient will be very cautious because he is not getting idea about the position of his body parts. He will lift it and put very cautiously. So you may be tempted to think it is a psychogenic gait disorder. Because at every level, our brain is getting information about where is your leg. So that how much you have to raise and how fast you bring it down, so that you correctly land on the floor. So that is not there.
Yes, ma'am.
So you told about tabes dorsalis, you told about diabetes, very good. So there the gait is described as stick and the stamp gait. You heard of that gait? It is called stick and the stamp gait. So my teacher used to tell, a tabes patient, which is not there now, in the olden days, when a tabes patient is coming from outside, you sit inside your consulting room and you can make a diagnosis. Why? Because patient does not know the depth of the floor, because unless he uses his vision, or he has to keep bending, looking at the floor and walking all the time. If that is not possible, he will use the stick to tap the floor, so that he will know where is the floor. But the moment, so then he will think, okay, I know this much is the depth of the floor. But the moment he lifts the stick from the floor, again his leg is not giving the information regarding the position. So he will lift his leg too much and bring it down with a stamp. So the typical posterior column gait is described as stick and the stamp gait. So first you will hear the sound of the stick. This is followed by the sound of the stamp. So stick and the stamp gait. So posterior column tract pain can be band-like sensation, Lermite sign, lightning pains, deep boring paresthesia, and you can have a ill-defined type of glove and stocking sensory symptom. Unlike peripheral neuropathy, it will not be length dependent. It can be simultaneously upper limb and lower limb, or it can be bizarre, one upper limb, one lower limb up to the groin, another one up to the ankle, or only one leg it can be. And third, when you examine, unlike peripheral neuropathy, where the reflexes will be depressed, in posterior column, induced glove and stocking sensation, reflexes will be preserved.
Yes,
so that is 5 types of posterior column symptom. And spinothalamic tract pain is, you know, it carries only pain and temperature. You have got an anterior spinothalamic tract and a lateral spinothalamic tract. Anterior spinothalamic tract shares crude touch and position, but posterior column is a more powerful touch and position sense dealing structure. So anti-spinothalamic tract alone is not capable of producing problems. Whereas lateral spinothalamic tract is the one which produces its unique features. It carries pain and temperature. Pain and temperature is a superficial cutaneous receptors. Unlike proprioception, which is a spindle afferent, pain and temperature is superficial cutaneous receptors. So spinothalamic tract pain will be superficial. Unlike the posterior column tract pain, deep boring paresthesia as if flesh is pulled out from the bones, I told. Whereas spinothalamic tract pain is superficial because the pain and temperature receptors are cutaneous receptors. And it will be depending on if it is an ascending spinothalamic tract, it will have a level. If it is from the crossing spinothalamic tract, it will be suspended. No precipitating factor, no relieving factor. Superficial burning or feeling of cold. So from your first symptom, the band-like sensation, I think there is no shock like root pain, nothing like burning pain of spinothalamic tract. So probably it is posterior column. Probably.
Yes, ma'am.
Next, you told that his right leg became numb, lower limbs, right lower limb and then the left lower limb.
Yes, ma'am. At first, there was tingling and tingling, numbness sensation and burning sensation first in the right limb, followed by the left limb within the 72
so
hours.
Both lower limbs got involved. What is
yes,
the tingling sensation? What do you call tingling sensation? You told tingling. What is the technical term you use for that?
Tingling sensation is paresthesia.
Paresthesia. No? So, what are all the positive sensory signs and symptoms you know of?
Ma'am, positive sensory symptoms are paresthesia, dysesthesia, hyperalgesia, allodynia, or hyperpathia.
Very good. So, what do you when do you call something as paresthesia?
When the sensory perception is absence of any sensory stimuli.
Excellent. So this is a sensory perception without any sensory stimuli. So it is a paresthesia. And the main character of the paresthesia is tingling. So paresthesia is due to excessive, it is due to destructive disease of the large fiber or irritative disease of the small fiber. So large myelinated fibers always inhibit the small myelinated fiber function. You know that you have got the C fiber, you have got the A delta fiber, you have got the A beta fibers. Whereas all the pain, when it becomes a chronic pain syndrome, even phantom pains, all these come through the chronic pains. So normally the chronic pain pathways are suppressed. That is called as the gating mechanism. In the spinal cord, gate control theory of Melsack and Wall, you might have heard of during pain transmission. So it is said that in the periphery, some gating is there. Large myelinated fiber will filter off all the rubbish information that the small fibers want to transmit. Because it is said that in 1 minute, there is about 1 minute, there is more than 60 million sensory information which can be perceived through our sense organs. That includes the seeing, hearing, skin, smell. So all these, but if you are starting to respond to all this, you will suffer from attention deficit hyperactivity. Because all these sensations are flooding your system, means which one you will attend to. So you'll become hyperactive, restless. So the most important function that the nervous system does is triage or filter off. It filters off unwanted sensations and takes only the wanted sensation. So this filtering function fails. When the posterior column is destroyed, it is unable to suppress the small fiber. Or when the small fiber is irritated, it does not get suppressed by the large fiber. So paresthesias indicate either a destructive disease of the large fiber when the small fiber is not properly gated, or small fiber is irritated, so it sends excessive stimuli and does refuse to get gated. So we already have a large fiber involvement, probably posterior column, by the band-like sensation. So it may can still be, that tingling sensation can be attributed to the large fiber involvement itself, because large fiber inhibits small fiber from the peripheral nerve up to the cortex. So several levels of gating. In the spinal cord, the gating is called the gate control theory of Millsack and Wall, taking place in the substantia gelatinosa of Rolandi. But this is taking place in the peripheral nerve and substantia gelatinosa of Rolandi. Then in the posterior column, when you reach the posterior column inhibits the transmission through spinothalamic tract. So that is why you might have heard that intractable pain in cancer or such diseases which are no more curable, you cannot fully sedate the patient all the time with morphine and pethidine and other things. So there are dorsal column stimulation. Posterior column electrical implantation is done and it is stimulated. When the posterior column is stimulated, it will inhibit the spinothalamic transmission. Or you do frontal leucotomy. Frontal leucotomy is done means patient will have pain, but he will not suffer from the pain. So posterior column inhibits spinothalamic tract. Using that mechanism only, dorsal column stimulation is done in the treatment of intractable pain. So this tingling can be attributed to the posterior column, which is already affected probably by the band-like sensation. And it started slightly asymmetrically. It started on the right side, and within 72 hours, according to it, became bilateral. So probably the posterior column was started, was involved, and probably it was involved in an asymmetrical fashion to start with, and soon it became symmetrical, and starting from the right side, probably the thoracic region. And it can explain your tingling also. Then you said some burning sensation, that is a spinothalamic tract pain. So probably after initially involving the posterior column, spinothalamic tracts also got involved. Possibility is there. But how he's an MTech person, so I think he will be able to explain correctly only. So we will trust his symptoms. So burning might have been there. That indicates the spinothalamic tract is also involved. This was followed by weakness of the right leg, which occurred next year sensation. Weakness on the lower proximal and distal muscles. So distal muscle, proximal affecting prior to the distal.
Yes, ma'am.
Okay. So why did you think the proximal was affected prior to the distal? What was the symptom that made you think like that?
It was evidenced
by proximal getting affected before the distal happens in what conditions? It's a very important thing. If it was there, you'll have to pick it up. So typically the proximal weakness comes earlier than the distal weakness in what all conditions?
In myopathy, madam, and
yes,
in element
muscle disease, very good. Second, because bulkier muscles are proximal. So muscle diseases start proximally and come distally with some exceptions. Of course, medicine is not always 1:1. There are distal myopathies. Second, radiculopathies, like acute Guillain-Barré syndrome. Or you have got chronic inflammatory demyelinating radiculopathies. So pluxopathies. So proximal becomes affected earlier than distal in muscle disease. It happens in acute demyelinating diseases like Guillain-Barré syndrome, chronic demyelinating disease like CIDP, or it happens in pluxopathy. So it is a very important thing which you have mentioned. So I want to know what made you infer. This is an inference. What you have written is an inference. What made you think that this person's proximal got affected earlier than distal? Because in this patient, with the way the symptoms evolved, we are expecting an upper motor neuron.
Yes, ma'am.
Upper motor neuron will produce weakness distal first or proximal
distal
first?
More than, yes, ma'am.
Why it will produce
upper motor will distal first?
Why, ma? Why distal first? Very good. Why upper motor will become symptom weakness? Weakness means demonstrable loss of power. That is weakness. No? So it will be distal more than proximal in upper motor neuron. Why? Would you like to tell me why? Because what gets affected in upper motor neuron is not muscles or nerves or roots or plexus. It is the movement. So upper motor neuron does not produce muscle paralysis, does not produce nerve paralysis or root paralysis, but what it produces is movement paralysis. So for movements, there is a fine coordination between agonist, antagonist, fixators and synergist. So a movement is carried out by the agonist, opposite movement is inhibited by the antagonist, and synergist and fixators help the movement to be carried out smoothly. For that, there is a mathematic formula. That is the movement code, movement motor schema. This motor schema is prepared by the upper motor neuron. And the motor schema is very fine for fine movements.
Yes, ma'am.
You might have seen hemiplegia patients apparently recovered, you thrombolized within the window period and patient recovered very well. He goes back to his office and let us imagine he is a typist of the extra years or a piano player or a musician playing on the harmonium and piano. He will be shocked that he is not getting his alternate movement. They are the fine movements. Grossly, you check his grip, everything is all right, very good. He goes to the job, he is unable to do the alternating movement. That is because the finest movement is alternate movement. You do alternate movement while typing, alternate movement while playing musical instruments. That is the one which gets affected worst, because fine movements need very careful formation of the motor schema between the agonist, antagonist, synergist and fixators. That is called as kinetic melody. Melody means music.
Okay.
Kinetic means movement. So there is a music of the motor activity is what is lost in upper motor neuron. So I want to know why you thought, because I am expecting an upper motor neuron in this patient. So if it was proximal more than distal, I will think maybe upper motor and lower motor neuron were both involved. Before that, drawing that conclusion, I want to know what made you think that the proximal was more affected.
Ma'am, as per the
You had
history,
difficulty in getting up from the chair. Was that the
yes,
reason? Was that the reason, ma'am?
Yes, ma'am. And he was unable to stand from the squatting position and from commode. And from the chair, he was unable to get up without the support. So it
But
suggests.
you see, before drawing that conclusion, okay, when we examine, we might have found L-Aman also, I don't know. But you see, when before drawing the conclusion, that weakness in the lower limb was affecting both proximal and distal, and proximal more prior to the distal. Instead, you can tell that my patient had difficulty in getting up from the chair. That's all. You see, getting up from the chair happens in upper motor neuron also. That always does not mean that the proximal part was weak. It is due to the stiffness. You clearly mentioned that he had stiffness. See, when you get up from the floor or get up from the in a bed or anything, the stiffness will prevent from, it is a weakness that will be distal in upper motor neuron, but stiffness will be there everywhere. And the stiffness will increase based on the increasing velocity. So stiffness may be the one which is interfering, not weakness. When you use the term weakness, we will be forced to bring a lower motor neuron into the problem of the patient, and then it will be indicating that the band-like sensation was there and there is a lower motor neuron. So both upper motor and lower motor neuron gets involved in some conditions. We call them as myeloradiculopathies, cord and the root. So are you going to think like that? We don't know. But I think that instead of drawing the conclusion that proximal was weaker than the distal, you can tell my patient had difficulty in getting up from the chair and getting up from the squatting position, but the semiology of the getting up was altered or not altered. Supposing it is a hip extensor weakness that produced the difficulty which you are thinking. You have said that the proximal got weaker earlier than the distal. In that case, semiology of the getting up from the floor will be altered. This I have discussed in many previous classes also. If the proximal hip extensor has become weak, patient will not be able to get up in the way that we get up normally. You see, when we get up, we pull our legs under the thighs, put our hands on the side, and get up with the pelvis or down. Whereas a person who has developed a proximal weakness will get up with the pelvis up. That is called hip up sign.
Hip up.
Because proximal muscles are weak, so he will put a trick movement using the erector spinae to lift the hip. So the hip will go up. That is called hip up sign. Whereas a stiff person will still be not able to get up, but the hip up sign will not be there. He will be slow. He will use the side reels. Sometimes he will not be able to get up at all. So he will have to be pulled up. But the semiology does not produce hip up sign. So hip up sign and the hip dip sign while climbing with a hip up while getting up from the floor. The hip will go up because I have explained in some of the previous classes which will be there in the YouTube. When the erector spinae has an origin from the iliac crest. And it is also throughout the spine. So when the erector spinae attachment to the iliac crest is used to pull up the patient, the erector spinae cannot do erecting of the spine. It can do only one work. When you are all here, you cannot be in your homes like that. So the erector spinae stops erecting the spine. It starts pulling the leg from the iliac crest, which is normally not done by the erector spinae. It is only a synergistic muscle. It is not the primary agonist of hip raising. When the proximal muscle is weak, that is brought to action. So it will switch off his spine erecting function. So patient becomes bent and the hip goes up. So that semiology alteration is there. Then only you can say that my patient has, he is describing that the way he gets up has totally become changed. Instead of the pelvis down getting up, he gets up with the pelvis up. Otherwise, a stiff person will have difficulty in getting up. That will be due to stiffness. Stiffness affects both proximal and distal part uniformly, unlike the weakness. If you say weakness, you will put element into the pathology. Whether it is there or not, it can be involved in some disease. It's a very bad prognostic marker. So is it there or not, we do not know. So instead of describing your inference, better tell what the patient experienced. So is it really weakness or stiffness? We can decide. Okay. Next one.
Yes, ma'am.
Next, he is unable to turn in the bed, you told. No? He is unable to turn in the bed due to the stiffness, or he is completely paralyzed below.
Due to the truncal muscle weakness, madam.
So he is severely weak. Huh?
Yes, ma'am.
So trunk stiffness itself can prevent him turning. Then the patient will be like a log of wood. If it is the trunk muscles, the trunk muscles, trunk flexion is taking place by your the rectus abdominis, assisted by the sternocleidoid mastoid and the ribbon muscles. So when you want to flex your trunk, you use the both sternomastoid, the ribbon muscles and the recti. If you want to turn towards the left side, you use the right external oblique, right internal oblique and right transverse abdominis. If you are wanting to turn to the right side, it will be the left external oblique, internal oblique and transverse abdomen. But if it is due to stiffness, it will not be in this pattern. It will be, you will be lying like a log of wood. So his trunk movement was restricted by stiffness or weakness. Okay, we will check during examination. I have a feeling it may be the stiffness. It may not be the weakness. I feel so, because weakness means a patient will have specific weakness while turning to the left side or right side, and muscles will be flail and they'll bulge out. They can produce phantom hernias. Rectus abdominis can produce a bulge in the abdomen. So and flabby abdomen. But the person is stiff, so maybe it is a stiff that is interfering with his turning in the bed also. I think so, but we'll have to elicit that history. Okay, ma. Next you said that his upper limbs are normal, bladder is not involved.
Yes.
So, so now your patient is having, so only this much is the symptom. No? Does he have any flexor spasms, any positive, negative motor symptoms, or their weakness is there, but he's not having any fasciculations, he's not having any myokymia, he's not having any flexor spasms, no?
Madam, yeah, he has stiffness in the both lower limb and
And
flexor
spasm
spasm
of
was there.
flexor. So he has flexor spasms also.
Yes, ma'am.
In that case, what I am sure he does not have any weakness. What interferes which is getting up and the turning in the bed is only the stiffness, not the weakness of the proximal. So the proximal more than distal difficulty is more due to the stiffness and not due to the weakness. So what do you understand by the term flexor spasm? So your patient started with probably posterior column.
Posterior
Next
column
is
lesion.
the mild involvement of spinothalamic tract, and third involvement of the corticospinal tract. And now he is getting flexor spasm. No?
Yes,
So
ma'am.
what do you understand by the term flexor spasm?
Ma'am, flexor spasm may be severe in posterior column lesion, like in demyelinating lesions.
Now
Or
you
it is
told
a
flexor spasm now. What thing you will find in the patient when you tell that my patient has got flexor spasm? So it will be sudden flexion of the limbs.
yes, ma'am.
It can come by a loud noise. It can come when the patient has to empty his bladder or when you touch him. So when some sensory stimuli is given or some noise is produced or when there is a bowel or bladder emptying, the lower limbs goes into flexion. Is he having that?
Yes, ma'am.
Because you have written
When
spasm of flexor muscles is
yes, ma'am.
present.
When
You
on
written no?
touching the yes, ma'am. On touching the cup muscle, he was having the flexion of the whole leg.
Very good. So it's a flexor spasm. So sudden flexion of the limb can happen when he is touched or when he tries to empty his bowel bladder or when a sound is produced, it will produce flexion. So far we have analyzed the structures that are involved. Flexor spasm indicate which structure involvement?
Ma'am, posterior column.
Posterior column is sensory tract now. Flexor spasm is a motor phenomenon. So sensory tract cannot produce that. So normally when your child is born, the child will be in flexion or extension.
Inflection.
Newborn you might have seen, no? Your cousins,
Yes,
you are not married, small boy you are, no? So in your family you might have relatives who have newborn babies, no? The baby
Yes,
will
ma'am.
be in flexion or extension?
Inflection, ma'am.
Very good. So baby is in flexion. That is to occupy minimum space inside the uterus. If the baby is extended abnormal, so much of space will be needed. So baby is in flexion to occupy minimum space. That is done by, because the baby's brain and all is not at all developed. At the time of birth, baby is in the spinal stage. So it is the short latency flexor reflex afferents. They are called FRA. They are coming from the 1B afferents in the muscle spindle. FRA or short latency flexor reflex afferents. They are keeping the body in flexion by operating through the intersegmental spinal reflexes. So a person with a weakness of the lower limbs goes into that stage. The way your legs are when you are born in an intermittent fashion. If it is persistent, he will be in paraplegia and flexion. He will be in full flexion only. You have said that intermittent spasm. So intermittently, the patient is going into the spinal stage of the baby. So that means the short latency flexor reflex afferents, which are suppressed when the child's nervous system develops, is getting disinhibited. It is released. So when it will be released? When it is, when there is destruction of the tracts which maintain extensor posture. So normally we have got extension, we have got flexion. So long latency flexor reflex afferent is the corticospinal tract that helps you to flex your legs when you are walking. Whereas extension is done by the spinal extrapyramidal tract, that is reticulospinal tract, dorsal reticulospinal tract and vestibulospinal tract. they belong to the spinal extrapyramidal pathway. That maintain the extensor tone. When you are standing, your leg is extended. That is maintained by the dorsal reticulospinal tract and vestibulospinal tract. So child
Yes,
is
ma'am.
born only with the spinal reflexes. And when the child grows slowly, the brainstem starts operating. So spinal stage, brainstem stage, cortical stage will tell. Development is spinal stage, brainstem stage, cortical stage. In the brainstem stage, dorsal reticulospinal tract, which is having its base in the pons and is coming through the
Yes, ma'am.
spinal cord and going to the cortex. So that is the dorsal reticulospinal tract. Then you have got the vestibulospinal tract. These tracts maintain the extensor tone. So normally, and it completely suppresses the short latency flexor reflex afferents or the 1B afferent, so that you are able to walk. If your leg is intermittently flexing when you are walk, you cannot walk at all. So to facilitate that, when the brainstem starts demyelinating in the child, SFRA or 1B afferents are completely suppressed. So your extensor tone myelinates, and after that, so at that time child will stand. Then the child has to walk. To walk, you again need flexion. For that, you get the long latency flexor reflex afferents or LFRA. That is the corticospinal tract. So the corticospinal tract and the vestibulospinal reticulospinal tract together are modulated so that you can extend your leg when you want to extend and flex your leg when you want to flex, so that you are able to walk. So the formation of the flexor spasm indicate the previously suppressed short latency flexor reflex afferents have become activated. Why they are activated? Because the person has become like the spinal stage of the newborn. Why? Because the reticulospinal and the vestibulospinal pathway, which maintain the extensor tone of the lower limb, is also getting diseased. So from the history, we get that the posterior column got involved first, plus minus mild involvement of the spinothalamic because some burning you said, and weakness is there, so corticospinal, and flexor spasm is coming. So it is the vestibulospinal and the reticulospinal tract involvement. So that is what is indicated by flexor spasm. Am I clear, ma? Did you understand?
Yes, ma'am.
Very
Yeah.
good. So these are the tracks involved so far. Now you said that the bladder bowel is not involved. No?
Yes, ma'am. Bladder bowel is not in.
You are sure, no?
Yes, ma'am. I asked because the history of is 1 month, but I repeatedly asked about the bladder bowel symptom, but he denies that there's no symptom of any hesitancy or retention of the urine.
Okay. So either in that case, you can say that it is an incomplete cord syndrome or
Yes, ma'am.
autonomic fibers are spared. That is what you will draw. So now at the end of the history, we think the structures involved are posterior column, corticospinal tract, vestibulospinal, reticulospinal, plus minus spinothalamic, and sparing of the autonomic fibers. So it is so normally when there is a spinal cord syndrome, we try to localize them so that you get the proper etiology. Pan cord syndrome. That means complete cord, spinal cord, acute transvection of the spinal cord, where all the tracts are involved. That's a pan cord syndrome. This is not a pan cord. Why this is not a pan cord? Because bladder fibers are still functional. So it is not a pan cord.
Okay.
You have got an anterior cord syndrome. Anterior cord syndrome is spinothalamic and corticospinal tract. And posterior cord syndrome is posterior column. What is the importance of knowing this? You see, pan cord syndrome, acute transverse myelitis, or acute necrotizing myelitis, or trauma to the spinal cord, where the spinal cord gets transected. Or you can have some vascular syndromes where the Adam-Keyes artery or arterialis cervicalis magna. You might have heard that spinal cord blood supply is anterior spinal artery and posterior spinal artery. So anterior spinal artery supplies everything other than the posterior column. Posterior spinal artery supplies only posterior column. Whereas at the level of lower thoracolumbar region, you have got an artery of Adam Kivis.
Adam.
It's a large radicular artery in the thoracolumbar region which supplies the whole of the spinal cord. So that will produce, when it is destroyed, it will produce a acute transection of the cord, Pankot syndrome. Similarly, there is an cervicalis magna, arterialis cervicalis magna, which is in the cervical region. That also can produce Pankot. So if there's a Pankot syndrome, you will think of acute transverse myelitis, necrotizing myelitis, or you have got a trauma. Rarely, if it is in this respect regions, it can be still vascular. Whereas classical anterior cord syndrome is vascular. Anterior spinal artery infarction will spare the posterior column and involve the anterior cord. Then you will look for an aorta disease or a vasculitic process, Tokayasu syndrome, with involvement of the anterior spinal artery. Posterior spinal artery involvement is little uncommon. So if it's a pure posterior cord syndrome, you might think of specific conditions like evolving beetle myelopathy or HIV myelopathy or neurosyphilis, as you said, neurosyphilis, or copper deficiency myelopathies. So these are posterior column, posterior spinal artery syndromes are less common. So this is not a Pankot because bladder is spared. This is not anterior cord because you are not having that much involvement of anterior spinothalamic tract, whereas most of the tracts involved are the posterior column, corticospinal, vestibulospinal, reticulospinal. So it is not an anterior classical anterior cord syndrome. It is not a classical posterior cord syndrome because tracts which are beyond the posterior cord are also involved. What is a hemicord syndrome? So spinal cord at the end of the history, is it a Pankot? Is it an anterior cord? Is it a posterior cord? Is it a hemicord? Hemicord is called as what, ma? Brown-Sequard syndrome.
Brown-Sequard. Yes.
So hemicord means ipsilateral posterior column, ipsilateral corticospinal tract, contralateral spinothalamic. That's a classical Brown-Sequard syndrome, which again happens in gunshot injuries, trauma, and if it is subacute, it is tumors. So always it is a destructive disease, not a demyelinating disease. Commonly, it was first described in war wounds when a gun goes through one half of the spinal cord. But if it is subacute, you can get it in tumors also. Classically, it is a hemicord syndrome. A Brown-Sequard is described in war wounds, but it can happen in tumors. Then it will be subacute and slowly progressive. Spinal gliomas, which are eccentric in onset, they can do that. So that is hemicord syndrome. So this is not a Pankot. This is not an anterior cord. This is not a posterior cord. This is not a hemicord. Can it be a central cord? Central cord means you should have more involvement of spinothalamic tract. So here the spinothalamic is very much less involved. In the central cord, the structures which are there are the gray matter. That will be anterior horn cells. And the next to that is the crossing spinothalamic tract. So gray matter like anterior horn cell involvement and crossing spinothalamic tract, if they are involved, you call it as a central cord syndrome. So this is not respecting anterior cord, posterior cord, hemicord, central cord, or Pankot. So instead, it is picking up many tracts. It has picked up posterior column, it has picked up corticospinal tract, and it has probably partially picked up the reticulospinal and vestibulospinal, that is causing the flexor spasm. It has relatively spared the spinothalamic from the history, very mild burning sensation you told, and it has spared the bladder. So it looks like a tractopathy. So this kind of conditions, you don't call them anterior cord, posterior cord, Pankot, or central cord. It is a tractopathy. So this some tracts are involved. But tractopathies can be chronic or tractopathies can be acute. So acute tractopathies are going to give us a diagnosis regarding the nature. If it is the myelinated tracts that is involved, it will be demyelination. If it is spinothalamic tract and autonomic involvement more, it will be vasculitic process because you have told clearly no joint pain, no skin rash, no alopecia. So if it is a ischemic myelitis producing a tractopathy like Sjogren's disease, Behçet's disease, in that case, it will be spinothalamic and bladder and less of posterior column and corticospinal. Short duration. Long duration tractopathies are degenerative conditions. Various type of HSP plus tropical spastic paraplegia, that will be long duration tractopathy. So this is a short duration tractopathy which is seeming to involve the myelinated tracts more and relatively sparing the less myelinated spinothalamic and the autonomic fibers. So the bladder and the spinothalamic symptoms are less. So at the end of the history, it looks like a selective involvement of some tracts, and what is common for those tracts is again the myelin. Weakness is more, proprioception is more, and vestibulospinal, reticulospinal, they are also moderately myelinated. So is it a demyelinating partial cord syndrome? Demyelination tractopathy is a possibility. This was preceded by a febrile illness.
Yes.
So following febrile illness, if you get a condition like this, what you will think? Post-infectious demyelination, which could be ADAM or acute disseminated encephalomyelitis, where the encephalon may or may not be involved. Second, infection triggering a primary demyelinating disease. So any infection can trigger multiple sclerosis. Infection can trigger NMO spectrum disorders. So, so is it a spinal form of MS, or is it an NMO spectrum disorder triggered by an infection, or is it a post-infectious ADAM-like syndrome? These are the things. See, because you said the bladder fibers are moderately myelinated fibers because they are autonomic fibers, and the spinothalamic fibers are less myelinated fibers. They seem to be less symptomatic. So from the history, I am thinking of a demyelinating disease, whether it is related to the infection or infection has triggered a infection triggered inflammation, not necessarily an ADAM. So these are the two possibilities I'll be considering. So you understood the pathomechanism of flexor spasm? Did you understand clearly? It's a flexor spasm happen when there is a release of the spinal stage or short latency flexor reflex occurrence, which are suppressed at the time of neonatal period, when myelination progresses to the brainstem. So when the extents are torn, maintaining tracts, that's the vestibulospinal and reticulospinal tracts are getting involved in the pathological process, which are inhibiting the short latency flexor reflex occurrence. Then you get the flexor spasm. It is a bad prognostic marker because generally reticulospinal and vestibulospinal tracts are the last tracts to get destroyed in any disease. So if they are affected, that means the disease is fairly severe and it is not a good prognostic marker. So flexor spasm is a bad sign. Other bad signs are acute Pancourt syndrome, long segment spinal cord involvement, LMN plus UMN involvement. Myeloradiculopathy means upper motor neuron is also involved, lower motor neuron is also involved. So when the upper motor neuron is involved and the lower motor neuron is paired, the oligodendroglial myelin from the roots can proximally proliferate, go into the spinal cord and myelinate the spinal cord with a qualitatively different myelin. Or if the lower motor neuron is affected and upper motor neuron is preserved, myelin from the oligodendral glia in the spinal cord can migrate into the roots and repair, even though the quality of the myelin is different from the LMN myelin. But if both upper motor neuron and the lower motor neuron is knocked off, it is like destroying the main switch and destroying the bulb. The chance of recovery becomes very, very poor. So this person has got one bad sign, that is the flexor spasm. Second bad sign is fairly fast, not that fast, but fairly fast. Otherwise, he is not having other bad signs, as I said, are acute total cord involvement LMN and UMN involvement, and presence of flux spasms. These are the rapidity of involvement. Multiple segment involvement. Several segments are involved also. The recovery is very difficult. So this is what we think. So here's a multiple tracks involvement, but it is an incomplete cord lesion. Preferable for picking up of the most myelinated as evidenced by relative sparing of the moderately myelinated autonomic fibers and the less myelinated pain and temperature fibers. But flexor spasms indicate a relatively bad prognosis. Probably it is a demyelination directly or indirectly related to the infection. So on examination, tell me. On examination?
Ma'am, on summary, and from the differential already told, madam, if you told from the history.
Examination you didn't tell, no.
Examination. On general survey, patient was conscious, alert, and cooperative. He is right-handed individual. Face is normal. Build was average. Nutrition normal. BMI is being 23 kg per meter square. Decubitus, his legs are extended at the hip and the knee, and plantar are flexed. There was no pallor, jaundice, cyanosis, clubbing, or edema.
What you specifically look for,
ma'am? Ma'am, in this case, we look for the second cranial nerve.
Very good. So you look for the second cranial nerve to know whether it is a NMO spectrum disorder or a spino-optic MS. So NMO spectrum and spino-optic MS can involve the optic nerve because you had a suspicion that there is a LMN involvement in the history, and whether it's a myeloradiculopathy, then you will have to think for seventh nerve. So my acute Adam-like syndromes can pick up the seventh nerve, lower cranial nerves. So 9th, 10th, 7th can be involved in Adam-like illness. It's supposing it is a vasculitic myelopathy, then you will have to think of facial sensation. So a person with a myelopathy, you look for the second nerve to know NMO spectrum disorder or spino-optic MS, sometimes even toxic myelopathies. Then you look for the seventh nerve and the lower cranial nerves. If there is additional LMN myeloradiculopathies, they pick up these nerves. Fifth nerve involvement will point out to vasculitis like Sjogren syndrome, where the fifth nerve gets involved. Then you will get a papilledema if there is an acute necrotizing myelopathy, or if there is a spinal subarachnoid hemorrhage, or you have got a tumors where Freund's-like syndrome, high CFs of protein will produce papilledema. So you will look for, so in a patient with spinal cord disease, you will look at the second nerve, you look for papilledema, you look for seventh nerve, you look for fifth nerve, you look for lower cranial nerve. Each one will give you a pointer to some diagnosis. Subacute myelopathies, you might find RP, because mitochondrial disorders. You might find gyrate optic atrophy. You have got some hyperammonia syndromes where you get myelopathy and gyrate optic atrophy. They are treatable. Even though they are subacute and chronic, they are treatable. And HSP plus syndromes, you can get optic atrophy. So these cranial nerves you look for in any spinal cord disease, and each one will give you a clue regarding your diagnosis. Okay, so it is apparently patient is lying with the extended limbs. Okay.
Next, ma'am, the pulse, blood pressure and the vitals was normal, and there was no abnormal sweating in his body. Sweating was normal and equal in both upper and lower limb and lower half of the body. Neck veins were not engorged, not palpable neck glands.
How will you, how did you examine sweating, ma'am? It again confirms that the autonomic is not involved in this body, in this patient.
Yes.
Now, how did you check that the sweating is normal? Natural sweating normal, how you will check? And induced sweating normal, how you will check? Natural sweating, we can measure the skin temperature. This is sweating maintains your skin thermoregulation. So you can measure the skin temperature, special thermometers are there. You can measure the skin temperature in the upper body and the lower body. Second, you can put your hands through. You will feel the moisture equally or not equally. Third,
Okay.
you can give the aspirin, a tablet of aspirin with a hot cup of tea or coffee. It will induce sweating. So that then you can palpate and you may be able to appreciate the moisture much better. Or you have got something called starch iodide powder or quinisarin powder, you might have heard. Quinisarin powder can be sprinkled all over the body of the patient and then stimulate sweating either electrically or with sound or with a cup of coffee and aspirin, as I said. Then if the body is sweating, those areas, quinisarin powder will turn pink. But nowadays, quinisarin powder is not used as it is considered carcinogenic. Even though for the short period when we are using, it is not going to have long-term effects. It is a banned thing. So you use starch iodide. For us, if you do not have the classical starch iodide powder, we can sprinkle the starch powder, which you use for starching the clothes. And you can mix it with betadine. Betadine is iodine. No. So in your ward, if it is not there, you can get the person to get the starch powder used for starching the clothes. So you put that starch powder and over, you can sprinkle, you can wipe the whole patient's body with betadine and sprinkle the starch powder. Give him a cup of coffee and an aspirin and look where the starch iodide turns blue. So starch iodide will turn bluish black where areas of sweating is there, and quinisarin will turn pink. Or quickly in your examination, you will put your hand only and you can ask for the cutaneous thermometer to the sister so they can give you, you can see the temperature. Okay, next one.
Yes, ma'am. On higher mental function, patient is right-handed person. GCS was 15 by 15. Conscious, well-oriented to time, place, and person. Memory, immediate, recent, and remote was intact. Intelligence is normal. No delusion, hallucination. Speech and language was normal. MMSE was 30 by 30, and language speech is normal.
Okay.
On cranial nerves, all the first cranial nerve smell sensation normal in both the side. On the second cranial nerve, visual acuity is normal both, and distant and near vision was normal. There was no defect in the pupillary reflex. Optic disc was normal, no blooding. And third, fourth, sixth cranial nerve extraocular movement is full in all direction, and there was no ptosis. And the sensation about the face is intact, and the power of mastication is normal. As evidence, the fifth nerve is normal. And the seventh nerve, there is no deviation of the angle of mouth, no facial weakness. And the eighth nerve examination, there was waiver localized in the midline, and there was AC more than BC by the Rinne's test. And in the lower cranial nerve, the palate rises equally on opening the mouth and vocalization.
Weber
Uvula is
midline
midline.
means you need not call localized because there's a
Okay.
contradictory, no. So Weber in the midline like that. Don't tell localized. Localized means you are meaning one side. It's not localized, it is in the midline. So I am just telling the word handling, no. Weber
Okay.
means Weber is midline, like that we'll tell. Very good. Next one.
Thank you, ma'am. On examination, striking of the shoulder of left and right and turning of the sternocleidomastoid is normal. There was to 11th nerve is normal. Gag reflex is normal. And the tongue on the examination of the 12th nerve, tongue has no deviation. Bulk of the tongue is normal, no fasciculation. The tongue position inside the mouth and outside the mouth is normal. And the neck flexor and extension is normal. On proper CNS examination, the cranium and the spine, no meningeal sign, no vertebral tenderness or deformity. Muscle bulk preserved on equal both lower limb, no abnormal movement, fasciculation, but flexor spasm noticed. On motor system examination, attitude of the patient lying supine position with both lower limb extended at the hip and knee and flexed at the ankle, both arm placed side of the body, and the nutrition as evidenced by the circumferential measurement is normal in both arm, forearm, thigh, and calf bilaterally. In the upper limb power 5 by 5 in all joints movement in the both limb like shoulder, elbow, wrist, and small muscles of the hand. And the power of the neck muscle is normal, and in the lower limb the hip extensor is 4 by 5 in the right and left is 3 by 5. and hip flexor is 4/5, and in the right and left is 3/5. Abduction is also 3/5 in the and left also 3/5, and adduction is 4/5 and left is also 4/5. In the knee flexion there is 3/5 in the right, and knee flexion on the left is 4/5, and extension is 3/5 on the right and extension is 4/5 on the left. In the ankle, plantar flexion is 4/5 and on the right and 4/5 on the left, and dorsiflexion is 4/5 in both limbs. And the small muscle of the foot, like EHL and small muscle of the foot, is normal in power, and truncal weakness was there. On reflexes, on
Here,
deep tendon
even though the power appears less, I think that it is due to stiffness, not due to
yes,
lower. Even the limb is stiff, the heavier part
yes,
you will have difficulty in lifting, but that is probably due to stiffness.
okay.
I still feel so, because with the flexor spasms, I am not thinking of any element involvement, because the limb
Yes,
is stiff, the heavier part of his body is unable to lift, maybe mostly due to stiffness only. It is having some therapeutic relevance also, because his power is not that bad. So if you reduce the stiffness, he might get ambulation. If the power is very bad, then you give antispasticity agents. Patient will not, patient will deteriorate, because in such a situation, patient may be standing on his stiffness. Here, I think stiffness is producing that is of therapeutic relevance. If the stiffness is producing an apparent decrease in the power in some groups, reduce the stiffness, the power will improve. But if the power is very bad, 0 or something like that, not at all moving, but patient is standing, that means he is standing because of stiffness. Such a patient, you should not use any antispasticity agents, because patient is not standing on his power, he is standing on his stiffness. Such a patient, you reduce the stiffness, he will become bedbound. So this is a patient where antispasticity agents are likely to help him in rehabilitation. Okay, next.
Okay. On deep tendon reflex examination, lower limb, the knee is exaggerated on the right and the both in the left. Ankle jerk was exaggerated in both the limbs, right and left, and clonus was present in both the limbs. Ankle clonus was present. In upper limb, in the biceps, triceps, and supinator jerk is normal in both the limbs. And superficial reflexes, plantar is bilateral extensor, and abdominal reflex absent. Cremasteric reflex absent, and bulbocavernous reflex is absent.
So there is no element. You can see that. No, everything is human. Next.
Yes, ma'am. On tone, there is tone increase in both the right and the left lower limb, and normal in both upper limb. On sensory examination, the crude touch and fine touch pain temperature diminished up to the D6 spinal level on both half of the body, and a zone of hyperesthesia just above the level of the D6, and vibration sense in the upper limb is normal. Vibration sense in the lower limb diminished, and that is dampens after the 5 seconds. Vibration
for his age, it should be at least 15 seconds in the angle and 20 seconds in the anterior iliac spine.
Yes, ma'am. And vibration diminished up to the D4 spinous process, and joint
very
position
sense.
So
looking for vibration over the spine is very, very useful and very, very localizing. So it will give you the exact MRI diagnosis like. And paraspinal muscles, are they flabby or stiff also, you can look along with that. That also gives a lot of localization. So very good, you look for vibration in the spine, very good.
Okay. Joint position sense is normal in the upper limb, and joint position sense is diminished in the lower limb. Although the power of the lower limb is low, so joint position sense is not reliable in the lower limb. Okay. So there was no cerebellar sign noted. On coordination, upper limb is normal in both sides and lower limb in normal, but query due to the low power. And the gait is a spastic gait.
Okay. What are the typical features of a spastic gait?
Spastic gait is like scissoring gait.
Does he have scissoring? You have the video, huh? Normally, no, the spastic gait will be normally when you are telling the inference, no, because when the examiner comes and he sees some gait, he will get angry with you. Instead, if you describe, you always have an option of discussing. The gait may be more than one tract also can be producing problem. In this patient, we thought posterior column is involved. So he can have a stamping. So
Okay.
first you have to describe. Spastic gait means normal gait is a heel first gait. So in a spastic gait, it becomes toe first. And because of the stiffness and the toe first nature, patient will circumduct. And he will drag because the phase long latency flexor reflex afferent gets affected, the stepping will not be there. So you could say that my patient is having a toe first gait and he is having slight circumduction and he is dragging. The stepping is not there. So I think it's a spastic gait. Or if he has got a stamping component. So you can say that my patient is also bringing the leg with a thud. So his gait is spastic plus sensory. That is expected in this case. Scissoring happens, does not happen in acquired adult onset paraparesis. Scissoring is typically seen in early childhood conditions like cerebral palsy or conditions like adrenoleukodystrophies, other leukoencephalopathies, which are degenerative diseases. Scissoring is not common in an adult acquired kind of paraparesis. So if you have to describe the gait, whether it has become toe first, is he circumducting, is he dragging, is he having an element of stamping, finally say that all these points suggest it is a spastic gait or whatever you want to tell. So among all those things, what components were there in your patient? Was he trying to injure the toe?
No, ma'am.
Gait is like the signature of the nervous system. Very, very useful in diagnosis. So in this patient, combination can be there. So always he can always describe the gait. When the patient starts standing, what is the stance? What is in between both feet? How much wide, narrow or wide? Then when he starts walking, is he able to clear properly? Now, does he start with start the gait cycle with the toe or the heel? Then is he able to do alternate flexion and extension of both legs? So is he having swaying, reeling or stamping? So whatever is there, you tell and then say that this is a, if you have the video, we can see, because I will be surprised if this patient has got scissoring. Scissoring indicates adductor spasm. Adductor hypertonia is seen in degenerative or early neonatal insult like cerebral diplegia and other things I said about the leukodystrophies. Acquired paraplegia, scissoring is very uncommon. Scissoring means one leg crosses over the other leg. That happens due to adductor hypertonia, which is common in cerebral diplegia, such conditions only, not in this kind of condition. Okay, whatever it is there, next time we go to the bed, you will see his gait properly. Okay, next.
Yes, ma'am. Others in autonomous, there is no resting tachycardia, no abnormal sweating. There is no meningeal signs and carnic signs and Bruggen's kind. There are spine is no bony deformity gibbous or no bony deformity in the spine. In other system examination, the cardiovascular respiratory system was apparently look normal, and parabdomen was soft and no organomegaly noticed. So on investigation, should we continue in investigation?
Yes. So after the examination, what do you think is your diagnosis?
After the examination, it is
again you have confirmed that autonomic fibers are not at all involved, and pain and temperature is involved. Huh?
Pain temperature is involved, but and crude touch, fine touch, and pain temperature involved up to the D6 spinal level, ma'am.
How severely involved? Mainly, you have told again posterior column, corticospinal, and spinal extrapyramidal system as evidenced by intermittent flexor spasm, and sparing of autonomic and mild involvement of small fibers with a definite upper level, and spine level vibration points to D4. So it's a acute, it's a definite upper level is there, and that is at D4, but incomplete cord syndrome. So at this point, what is the clue? Will you like to consider Adam? Will you like to consider NMO? Would you like to consider a vascular syndrome? Or would you like to consider a primary demyelinating disease unmasked by a infectious stress? That can happen. So what becomes the order of priority at the end of your history?
And history, ma'am, I would like to summarize that patient has the acute transverse myelitis and probably on the D4 spinous level, and probably the etiology is being the demyelinating, which is post-infectious in condition.
But generally, you see, as all these are possibilities, but when you arrange the differential diagnosis, if our history is correct that the bladder, autonomic are all spared, in an acute transverse myelitis, you rarely see that. I am sure that you might have in your duty rooms many times found patients who go with an acute retention of urine to the urologist. They catheterize the patient thinking some kind of an ureteric spasm or something, and the next day when he gets up from the bed, he is paralyzed. That's the typical history of an acute transverse myelitis. It is an intrinsic disease, and it starts with the bladder fibers involvement in good number of cases. So that is paid now. So as I told, it is not a PAN code. A PAN code only you will call it as an acute transverse myelitis. So it's a patchy code. So some tracks are selectively involved. So that makes the post-infectious Adam as a lesser possibility. So it becomes lower in the list. NMO spectrum also mostly it's a PAN code, whereas a patchy code is a primary demyelinating disease. So whether it is a spinal form of MS becomes the first possibility, because even after examination, it is a patchy lesion. Autonomic is paid still. Bladder is not at all involved. Even though patient is having flexor spasms, bladder is not involved. So my first diagnosis, all those becomes the DD, but my first diagnosis will be a patchy cord syndrome, not an acute transverse myelitis. So it's a patchy cord syndrome as evidenced by complete sparing of autonomic, weakness is only partial, and pain and temperature probably less involved, and posterior column most involved. So it's a patchy syndrome. So I will consider my first possibility as spinal form of MS precipitated by systemic infection. Systemic infection, vaccination, surgery, trauma, stress, all these can unmask the first episode of MS. So my first diagnosis, considering the patchiness of the lesion, it is most probably a spinal form of MS. And NMO, all those things become lower. Adam will be next. So spinal form of MS will be my first diagnosis, because it is very important to prognosticate relapse and plan interval treatment and do the investigations, whether you are going to do oligoclonal band, multimodal evoked responses, and MRI of the brain also. All those things are there. So my first diagnosis will be a spinal form of MS. Next, I will consider an incomplete Adam, and lower in the list only will be the NMO spectrum disorder. Ischemic and other things I will not consider as a possibility at all in this situation, because it is not respecting a typical vascular territory. Posterior column and corticospinal are involved. That is not in a vascular zone. Posterior column is postspinal artery, corticospinal is antispinal artery, but they are also bladder and all those things are spared. So I will not consider ischemic as a possibility. Okay, let us see the investigations. If you have the MRI, we will see the MRI.
Yes, ma'am. On investigation, the complete blood count was an LFT and RFT was normal, but the MRI cervical spine and lumbar spine is normal, madam. And MRI brain is normal. The visual effect potential was within normal limit. And on CSF examination, the cell count is 8 cell per cubic millimeter, and cell type is all lymphocyte. Protein is slightly raised, 40 milligram per DL, and sugar is 87. And at the time, blood glucose was 168. And CSF for ADA was negative, and CSF for oligoclonal band is negative. And blood for ANA is negative done by the HEP2, and HIV anti-HCV HBsAg was non-reactive, but the blood for CSF, blood and CSF for aquaporin 4 antibody was positive. This
Very
is the
typical because spinal cord, you said the MRI is normal and patchy involvement. Okay, let us see. Clinically, I will not call it as an NMO.
yeah,
And MRI also not showing. MRI long segment involvement is the typical feature, and VEP will be at least subclinically showing abnormality. Let me see the MRI. Show the MRI. Let me see.
MRI is normal, ma'am.
Let
It
me
is
see.
the long segment.
We'll see the images. Hmm. You did it in which Tesla, MRI?
3 Tesla, ma'am.
3 Tesla. 3 Tesla. MS can produce patchy lesions which can be missed if you do in 2.2 or 1.5 Tesla. 3 Tesla will pick it up. I am surprised that with this much disability in the patient, MRI is not showing. Axial cuts you have, axial cuts at D4 level. D4 is the level, no? It has to be involved. It is very difficult to believe that this MRI is
Yes,
not
ma'am,
showing anything, but I want to see the axial cuts, transfers.
axial cassette, it's at present, ma'am, not available, ma'am.
Okay. I will want you to wait and repeat the acopanol. Which lab you did it, no? Reliable lab, huh?
Ma'am, in our hospital, ma'am.
So sensitivity, specificity is how much in your hospital?
It is
There
quite
will have a lab
good.
sensitivity specificity, no? How much false positive they get, we have to, because this kind of a normal, again favoring an MS only. MS will produce multiple small patchy lesions which need not show any, whereas NMO will show long segment lesions. So this is very unusual in NMO. So I would like to still consider the possibility of a primary demyelinating disease like MS, not NMO, not ADAM. ADAM also will show significant lesions in T2. It is not showing, means again the possibility goes in favor of MS only. So yeah, I will, because treatment in NMO spectrum disorder, interferons and all those things are not going to be useful. Whereas you have to use steroids, azathioprine, mycophenolate like that. Whereas MS, you'll have to use treatment options are different, which will not work in this condition. So I will want you to just see the axial cuts. Definitely they are going to be patchy lesions as we clinically thought correctly. So the possibility, I will believe my clinical sense much better than any laboratory. Yes, laboratory data has sensitivity, specificity, all those things. So this patchy lesion is very clear throughout. From your history to examination, patchiness is clear. That is supported by an apparently normal MRI. Apparently normal MRI will never be seen in a condition like NMO where you get large lesions. So I will keep the laboratory aside. I will go to the laboratory and ask how much is the sensitivity and specificity. So I would like to get it repeated after some time. At this point of time, I will still consider the possibility of a patchy cord lesion and a young person and relatively preserved images that will favor a primary demyelinating disease. Even though it doesn't qualify for the radiological criteria where you should find 9 lesions, infratenderal, supratenderal, all those things, still small patchy lesions never happen in NMO, never happen in ADAM. But they happen in MS. So I would like to verify the sensitivity and specificity of your lab. Each laboratory will have its own sensitivity and specificity. You'll have to find out. I will not call this as an NMO spectrum disorder because the lesions are very patchy.
Yes, ma'am. I think
so,
we will repeat the MRI and
demyelination only. I think you can take a thin axial sections. It is definitely demyelination, but I feel it is spinal form of MS probably. So much disability is there. MRI being normal, you'll carefully look at the axial cut. MRI normal with so much lesion is never possible with NMO or with ADAM. So I would keep following up the patient. I will repeat the NMO, I will repeat the oligoclonal band, I will repeat the multimodal evoked responses. Now we will give him methylprednisolone 1 pulse of 1 gram for 5 days. Then I will supplement him with a secondary immunomodulator which will work for both like azathioprine, and follow up the case without a specific label of NMO. I will not give him the label of NMO now.
Oh.
You will have to,
No,
he is
here-
highly educated person. You can tell the dilemmas. Dilemmas happen like this. So you have to tell that this is not a typical NMO, not a typical MS, because we are clinically it is a spinal MS only.
Okay, ma'am.
Radiology, you look at carefully the axial sections now.
Yes, ma'am.
NMO label, you will wait for some 2 to 3 months, repeat it, watch the patient for evolution, and then only you call him NMO.
Okay, ma'am.
You understood why I am telling like this? Patchy lesions are
Yes, ma'am. Patchy lesions are there. Yes,
typical in primary demyelination of MS type rather than NMO type.
NMO.
Because treatment options are going to be different for both the conditions. So that is why I am thinking that you should keep the patient under follow-up, look at the sensitivity, specificity, look at the axial cuts, and tell the patient that it is a demyelinating disease, but belongs to what category, needs some more time to decide. That is what you will tell your patient.
Yes, ma'am.
Any doubt, ma'am? So this is not a transverse myelitis, it's a patchy cord syndrome.
Yes, ma'am. Got it, ma'am.
Patchy cord syndrome due to demyelination. That is what you will call it.
Yes, ma'am.
Any question, ma? Very good, ma. Your very good presentation. Your presentation was excellent. How to differentiate UMN versus LMN bowel in history? You see, this person bowel bladder not involved, but I'll tell you. You see, you have got a Lapidus classification at the bedside. You have got so many classifications of the bladder. But what we commonly use very easily is the Lapidus classification. So bladder history, you have to take first pre-voiding phase, voiding phase, post-voiding phase. You have to ask the patient what happens in the pre-voiding phase. What in the pre-voiding phase? So bowel I will come to. The pre-voiding phase, is the person able to appreciate bladder fullness? Does he appreciate any bladder pain? Then is he able to control micturition if he wants to wait for another person inside the toilet to come out? Third, is he able to initiate micturition on his own? Can he, so are you able to restrain? Are you able to initiate? Are you able to feel the pain? Are you able to feel the fullness? That is in the pre-voiding phase. Then the voiding phase, are you able to voluntarily initiate micturition? Can you stop the micturition in the midstream? How much is the volume of urine passed during single micturition? At the end of micturition, is the person feeling that the bladder has been completely emptied, or is there a feeling that there is incomplete emptying? Then in the post-voiding phase, is the person feels any post-voiding fullness, post-voiding dribbling? And this much information about the voiding. Then you have to take next history, how many times he passes urine in a day and night, and how much is the volume of urine passed during each micturition. That is called bladder diary. So bladder diary consists of number of micturations per day, amount of urine passed per day, per micturation, what happens in the pre-voiding, what happens in the voiding, what happens in the post-voiding phase. After, so that information is collected. You have got you have got Lapidus classification. You have got a cortical uninhibited bladder for the frontal lobe, cortical retention for the parasagittal region. Then you come to the spinal cord. You have got automatic bladder, or you can have precipitancy, you can have hesitancy, sensory denervated bladder, motor denervated bladder. So in the spinal cord, all 5 things happens. And in the lower motor neuron, you have got an autonomous bladder. So is it an upper motor neuron bladder, may be automatic bladder in the spinal cord, or in the conus cauda lesion, it is autonomous bladder. So how are you going to differentiate? So automatic bladder, as the word implies, pre-voiding phase, patient may or may not get the fullness or pain based on the completeness of the lesion. If the lesion is complete, patient will not get any sensation, no sensation of fullness, no sensation of pain. Partial appreciation of fullness or pain happens if the lesion is incomplete. Second, patient cannot voluntarily initiate micturition. That is why it is called automatic bladder. Once the bladder storage reaches about 200 to 300 ml, which is storage based on the sacral center, automatically bladder will start emptying. So patient cannot initiate micturition. He may partially or not at all appreciate fullness and pain. He will not have any voluntary control over initiation of micturition. He cannot wait for the person inside the toilet to come. It will automatically start. He cannot automatically stop, and he will empty about 300 ml of urine, which is the capacity of the sacral center. And at the end of that emptying, there will be automatically emptying will stop, and patient will have residual urine as evidenced by post-voiding persistent fullness or post-voiding dribbling. So upper motor neuron for the spinal, it is automatic bladder. These are the points. Pre-voiding phase, fullness and pain is either totally not appreciated if it is an acute transverse myelitis, or partially appreciated if it's an incomplete cord lesion like this patient. And patient cannot initiate micturition. He cannot terminate micturition also. So initiation takes place automatically. So he has no restraint. And when the bladder empties, he cannot stop in the midstream. A good amount of urine will be emptied, about 300 ml. At the end, he cannot voluntarily stop. It will stop on its own. And after stopping, patient will have residual urine as evidenced by post-voiding dribbling and post-voiding fullness. Whereas what is an autonomous bladder, patient will never have any, only the bladder wall center is there. Even the sacral center is damaged in the element bladder. Only bladder wall center, they have no sensations. It is beta receptors in the body and alpha receptors in the sphincter. So alpha receptors will close the sphincter, beta receptors will relax the body. So it will be an element bladder, will be a bladder which has no sensation. Neither fullness nor pain is appreciated. It is a large bladder. It's a large bladder, unlike the upper motor neuron bladder. And this bladder will empty by the weight of the urine. About 1.5 liters of urine can be accommodated by relaxation of the beta receptors and contraction of the alpha receptors in the sphincter. And after that 1.5 liters accumulate, the bladder will start dribbling. Because of the weight of the urine, every amount of urine secreted after the 1.5 to 5 liter is crossed will dribble. So total loss of sensation in the pre-voiding phase. Patient cannot initiate any micturition. Patient in fact has a large bladder. He is continuously dribbling. That is the element bladder. Understood? You should take the bladder diary, number of micturations per day, amount of urine passed, pre-voiding phase, voiding phase, post-voiding phase, document that and put it into this. So UMN automatic bladder will be no sensation, partially preserved or not preserved, cannot initiate micturition, empties intermittently, empties about 200 to 300 ml, cannot stop in the midstream, at the end incomplete micturition and residual urine. LMN bladder, no sensation at all, large bladder, continuously dribbling, no intermittent micturition. Understood?
Yes, ma'am.
Okay. Somebody's, some other question was there, huh?
Yes, ma'am. Also, there's a YouTube question, like it says, okay, should we offer disease-specific agents after combination of diagnosis or after 4 weeks? Like
now you will give him steroids. He's a young man. That will work for both. Second, you will start him on a second line immunomodulation now, which can be azathioprine. Then you wait and repeat the, because I am thinking it is more in favor of an MS and not NMO. Because he might need.
Plasmapheresis will help here.
Now, first you can try is people tell that plasmapheresis combined with methylprednisolone is more effective rather than either methylprednisolone or plasmapheresis alone. So you give
Okay.
methylprednisolone and combine it with more than one therapy will more than one combination of therapy gives better results. So you can combine both. Alternate day you can do. One day plasmapheresis, next day you can do methylprednisolone, like that you can do. What I am telling, wait for some time to give him a label. To give a label as NMO, so many atypical features are there other than this acoparin antibody alone. So that whether it's a false positive, I will want to know before giving. We'll call him as a patchy cord syndrome due to demyelination. Discussion you'll write. As the MRI is not showing any typical lesions of NMO. And clinically also patient has got a patchy incomplete cord lesion. Those pictures are not at all typical of NMO. Possibility of a spinal MS is considered as the first possibility and NMO becomes a second possibility because of the laboratory data only. Like that.
Ma'am,
Any other
just
question? Which tell me, ask.
just a query, ma'am. Ma'am, in high cord lesion, the mechanism of the balaclava type of sensory loss, would you kindly explain in few words, ma'am?
You
In
see,
the
it is
high cord lesion.
quintothalamic tract. Quintothalamic tract has got a close to the midline. It is the perioral region, and outside is the preoral region. So, if a lesion is starting from inside, like a demyelination, or a vertebrobasilar ischemia, or a brainstem glioma, it is the central part of the quintothalamic tract which gets involved. Otherwise, you get streptomycin toxicity. It involves the quintothalamic tract. After streptomycin, patients might experience perioral, that is onion peel. Whereas compressive lesions, it compress from outside, high cervical cord, craniovertebral anomalies. They involve the outermost fibers of the quintothalamic tract first. That will produce a balaclava helmet pattern of sensory. Any other question, ma'am?
Ma'am, there's one more question, like how to differentiate between UMN and LMN bowel.
Bowel. UMN and LMN bowel, clinically, it is only constipation. So clinically, you use only the bladder. Bowel is constipation, whether it is LMN or UMN. So if you are very particular whether there is a combination of an UMN bladder and an LMN bowel, which never happens, which does not happen. But if you want to demonstrate, you have got a dynamic pressure studies, like you do the urodynamic studies, you have got a dynamic studies for the rectal and large bowel pressure. That can be done, and then you can demonstrate where it's LMN. Otherwise, because UMN bowel and LMN bowel both present as constipation, so clinically you cannot. Clinically, we use only the bladder and
Yes.
extrapolate it to the bowel.
Yes, ma'am. Ma'am, one more question, like why abdominal and cremasteric reflexes become lost in UMN lesion unlike deep tendon reflexes?
Because deep tendon reflexes are kept inhibited by the higher centers, they get released. So when the deep tendon reflexes are elicited in an upper motor neuron, it's a release of the deep tendon jerks. Because when during the evolution of postural reflexes, if you are having the reflexes, whenever you stretch your muscle, you contract and fall. So when you progress to the higher level of myelination, higher centers inhibit the reflexes. Reflexes are no more needed. When you are able to do a voluntary activity, that is not needed. Whereas superficial reflexes are polysynaptic.
Yes,
they are not. They are having multiple levels of control, so they get involved in upper motor neuron. Whereas they get abolished because it is polysynaptic. Whereas stretch reflex is whenever a muscle with an intact nerve supply stretch, it will contract. That is useful in the spinal stage. So if those reflex activities persist when you start doing voluntary activity, you cannot do your activities properly. Everything will happen in a reflex pattern and not in a voluntary pattern. So higher center suppress it. When there is a cord lesion, which disconnects the higher information from coming to the stretch reflex, it is like the flexor spasm, I said. So that becomes elicitable.
Thank you, ma'am.
Any other question?
Mm,
So good presentation, ma'am. Thank you. Good.
Thank you,
Next.
ma'am.
Thank you, ma'am. Ma'am, it was indeed a very comprehensive clinical class. It was very useful for us, and thank you for guiding us, ma'am, and teaching and throughout. We need your blessings throughout and your guidance as well. It was a great effort by Dr. Subra. We could learn a lot because of your well-prepared presentation. We also thank all the participants who were enthusiastically answering and were very actively involved. Thank you, one and all.
Thank you.
Thank you, ma'am.
Thank you, ma'am.
Thank